Welcome, everyone, to our concurrent session. My name's Jenny DeCastri, and I am from Island Health. And I'm very happy today to introduce to you Dr. Myriam Farah. She will be talking about hemodiafiltration. It is coming. It is coming to all our units. We have machines that are now capable. So it's there. And along the way, we've discovered a few little bumps. So it's great that she's able to come and speak to us today and give us a little bit more information.
Thank you, Jenny. Thank you very much for coming today. So I have been tasked with giving education information, but mostly a little bit of experience and anecdote about how hemodiafiltration has borne out in our program, and really what we have learned not only from the world but also from our own experience in our program as we look at, as Jenny said, hopefully rolling this out provincially at some point in the future. So basically, hopefully what we'll accomplish today with hopefully quite a bit of time for discussion is to really address what hemodiafiltration is, why people around the world do it, how do you do it, why might you not want to do it as you're looking at your own program and the capacity and the capabilities that you have, and really what to do right now to help us move forward in looking at this. And what I'd like to do before sort of getting into the specifics of HDF is preface everything you're going to hear about HDF and the evidence and the lack of evidence in that area by showing you this slide. And this slide basically captures a snapshot of a dialysis patient who starts dialysis and the likelihood that they're going to be alive 1, 3, and 5 years after they have started dialysis. Now, of course, this is all comers. It includes both young, old, diabetics, non-diabetics. So, of course, there are people who do much better and much worse than this. But overall, in the last few years and decades, despite all the new fancy machines, all of the new tubing, all of our new dialyzers and everything, mortality in dialysis patients is largely unchanged. By 1 year, we're looking at about losing 10 to 20% of our new starts, and by 5 years, about 50% of our patients, unfortunately, have passed on. This, in my mind, summarizes any trial that's probably been done or is being done in nephrology or dialysis patients. It doesn't matter which intervention you do and what the control is, it is very difficult to change mortality in dialysis patients. And that's largely because there are dialysis patients who also have a lot of other comorbidities that will likely claim their lives. So rather than shifting or focusing on how can we make dialysis patients live longer, the focus in dialysis, in the world of dialysis, has largely become to how can we make them live better? How can we make life that's left of better quality and freer of symptoms? So largely what we focus on is controlling fluid and salt balance, avoiding doing bad things to them during dialysis, avoiding the bad things that happen during their interdialytic stretches, whether they are very long or very short, and really focusing on managing and minimizing dialysis-related symptomatology, uremic symptoms, and really focusing on quality of life. And we do believe that a lot of those symptoms are potentially or largely influenced by how well we're dialyzing these people, how often, how long, and what type of clearance mechanisms we're using to really get rid of those uremic symptoms, that uremic burden that our patients carry. So everyone here in the room is familiar with our current practice of trying to give patients more dialysis by either dialyzing them more frequently or longer, whether that's at home or in a facility. But adding an additional clearance mechanism in addition to the diffusion that we use in dialysis is really the crux of hemodiafiltration. What HDF basically is, it's the addition of high-volume ultrafiltration in conjunction with dialysis. So you still do dialysis, but you're also now doing a high volume of ultrafiltration to pull off liters and liters of fluid and get added convective clearance with this high volume ultrafiltration. We're not talking the 2 or 3 liters that we use in dialysis to attain goal weight. We're talking 20, 30 liters of fluid removal during HDF. Now, of course, our patients' plasma volumes are not that large, so to maintain our patients' hemodynamics and obviously to not kill them during HDF, we have to give fluid back. So hemodiafiltration basically relies on high volume ultrafiltration with concurrent replacement fluid that's given back to the patient. There are 2 major modalities of how HDF can be performed, and both of them depend on where the replacement fluid is given back. On this slide here, I've shown you when replacement fluid is, I guess you can't see the pointer. So when replacement fluid is administered what we call post-filter or post-dialyzer. As you can see in this slide, you have typical blood flow entering the dialyzer. You have spent dialysate that's pulled off from the other side. You have an additional ultrafiltration volume that's part of the effluent there. And then you have replacement fluid in the purple bag that's, in this case, being administered after the dialyzer and then given back to the patient. This is the ideal or the preferred form of doing a hemodiafiltration. And the reason for that is because the replacement fluid hits the blood after it's gone through the dialyzer already. So it doesn't do anything to the blood hitting the membrane. However, as a result of this, you can imagine the blood that enters that dialyzer and has quite a large volume of water removed from it eventually becomes quite viscous as it goes through that filter. So there is a risk that the filter can clot off. And in order to try to mitigate this risk, we try to limit how much fluid we're pulling off depending on the blood that's entering the dialyzer. In technical terms, that's referred to as the filtration fraction, and basically what we're trying to do is to say we want to limit the total amount of ultrafiltration to about a quarter of the incoming blood flow rate. So the two are very intimately linked together. In other words, if a patient has a blood flow rate of 250 only, you can't pull off 200 mils of water and have 50 mils left in that filter. It's going to clot within the filter. So it's the quarter of the blood flow rate, or 25%, that we limit that as, and that's known as the filtration fraction. The other way, of course, to do hemodiafiltration is to say, well, I don't really want to risk my filter from clotting off. Why don't I just give the replacement fluid before the membrane so I can really dilute out the blood and the filter won't clot? And that absolutely is a possibility. In fact, many of the centers that use CRRT use this modality in order to do that. However, as you can imagine, if you dilute out the incoming blood with sterile solution and sterile fluid, the concentration of all the things we're trying to get rid of is lower as it goes through the dialyzer. So you're diluting out your blood, and the efficiency of solute clearance is therefore going to be jeopardized. The only way to get around this is to use more, to remove more and to replace more. And typically that's about 2 times the amount that you would use in post-dilution. In other words, if in post-dilution you would use 20 liters of ultrafiltration, in pre-dilution you're looking at about 40 liters. Which one you end up doing is really a choice that's up to you, as well as the machine capabilities. Personally and anecdotally speaking, clearance is better with post-dilution HDF, and most of the trials do use the post-dilution method, mostly because of this fear of diluting out the blood as it hits the dialyzer. So far, does that make sense? Yes, okay, great. So this is what an HDF circuit looks like. It's a little bit of a conceptual difference. So here I've shown blood coming in at a rate of 300 mils per minute in this patient's case. We have programmed in a ultrafiltration rate of about 10 mils per minute just to get rid of the fluid that you would need to get rid of to get the patient to euvolemia. So in other words, the fluid off to attain target weight would be something like 2.5 liters for some of our patients. And then a replacement fluid rate of 80 mils per minute, because we're trying to get it below that quarter of the incoming blood flow rate. So in other words, our total ultrafiltration rate is going to be 90 mils per minute. If you look at a 4-hour run, what this is going to get us is 2.4 liters of weight loss, so ultrafiltration to get the patient to euvolemia, 19.2 liters of replacement fluid that we're going to give back because we pulled off the exact amount. And in total, we're going to have a total ultrafiltration volume of 21.6 liters for this patient in this run. Now, you can see how that's going to actually look conceptually. You've got standard dialysate that's pumped in and goes through 2 filters that are installed in series, and most of the new machines have similar setups no matter which company you're looking at. You've got 2 filters that are installed in series. The dialysate that goes through the first filter is technically ultra-pure dialysate if manufacturer recommendations are being followed. Some of that is going to get pulled aside and run through a second filter, at which point, if the filter is intact and you're doing all your upkeep and following the manufacturer's recommendation, it now should meet criteria to be usable as substitution fluid. In other words, it is considered safe for direct infusion into the patient. The important thing about this is that most of the machines won't run all of the incoming dialysate through that second filter, only the amount that's necessary to create that substitution fluid. And so, in other words, that substitution fluid then now hits the blood flow, the outcoming blood on the venous side, and all of it is given back to the patient. So this is what a typical HDF circuit looks like, no matter which machine you really look at. So why do this? Seems like it's more work for the machine at the very least, more tubing, more setup. Why do this? Well, it all sort of rests on the recognition of the challenges that we have with removal of non-small solutes during usual hemodialysis, and largely also the understanding that even with good removal of small solute clearance, some of our patients just do better with more. More is really more for some select patients. So it is the hope that this added convective clearance contributes a large amount of, or at least a significant amount of, middle and large molecule removal. We're not talking potassium, creatinine, urea, calcium. All of those things we know we can make better within a couple of hours on a standard dialysate run. We're talking potentially larger molecules, potentially phosphate, uremic markers, inflammatory cytokines, protein-bound solutes. These are the things we're trying to get at because these are the things that are likely contributing to the morbidity in our patients. So the hope is that we can get rid of those things. And of course, the hope is that this removal of these things lessens their cardiovascular burden, their inflammatory milieu, and their uremic symptoms and burden. And of course, what we all want is not only for them to feel better, but to really have a better quality of life, less morbidity, and hey, maybe even less mortality. So this is how the concept of HDF was born out, and this is really what people are after, or were after, and still are largely. So has that actually borne out? So this is the current state of affairs, and I won't bore you with every single study. We're going to touch on some studies, but I won't bore you with all of the details. I can summarize the evidence by telling you there is no conclusive evidence that if I write an order in a patient's chart that says HDF, that patient is going to live longer. That's the first truth. However, there are potentially and likely a lot of clinical benefits to using HDF for our patients. But there are 2 caveats to that. One is that it's not a matter of just ordering HDF. It's a matter of ordering good and enough HDF. So in other words, there's something to be said about how it is performed and how much of this added convective clearance we're actually giving and delivering to our patients. So not what's prescribed, but what's actually delivered. And the second is that we don't know if the benefits of HDF are really because we're using more convective clearance or because might be other things that HDF also does that's good for our patients. In other words, we're using ultra-pure dialysate all of a sudden now. We're using substitution fluid that is infused into the patient. We are potentially selecting patients that might do better in general. And hopefully, some of the things we're doing with HDF are really just lessening the things that can go wrong during their dialysis runs. And perhaps that's what keeps these patients from doing worse than their counterparts. So while it probably does not change mortality, it may, but we don't have evidence for that, there are a lot of potential benefits, and we'll explore those. But we have to keep in mind that if we're going to implement HDF in our centers and provincially, we have to look at the logistics, we have to consider the pros, the cons, and the hows, and how to really do this. So let's talk about one of the clinical benefits of HDF. And that's the one that really is, the Achilles heel of dialysis. It's intradialytic stability. I have shown you one typical RCT and then a systematic review, which was just completed last year. And both of them, we won't go through the details, but they're listed there for you. The data is overwhelmingly positive for HDF being able to confer better hemodynamic stability for our patients. That doesn't mean every single patient that is prescribed HDF, in fact, will do better, but in studies, it has borne out in a randomized controlled trial manner. Why would that happen? A lot of theories about this. What's well accepted now around the world is that there is a thermal cooling that happens with the administration of substitution fluid directly to the patient. And there is a mild amount of sodium loading that happens during HDF no matter what you do about it, and that's just the nature of the substitution fluid. Now, does that bear out in really increasing interdialytic weight gains? Hasn't exactly been looked at in a study setting. Anecdotally, in our hands, I can tell you it has not. So while there is probably a mild sodium loading effect, it is not. We have not found it to be significant in our patient population. And I would say, I think Dr. Kia can attest to that, hemodynamic stability for us has been a hit or miss. Some of our patients do extremely well. Some patients do not see a difference at all. The next big thing is this concept of uremia and inflammation. There are a lot of observational trials that have looked at in vitro data. In other words, can we remove certain molecules? IL-6, IL-2, TNF-alpha, things that people really care about in sort of in vitro studies. Inflammatory markers, even phosphate removal and phosphate kinetics, as well as protein-bound solutes. All of these bear out in observational trials to be better removed by hemodiafiltration. However, when we've tried to take that to the next level and look at, well, does any of that stuff actually make a clinical difference? In other words, by removing a little bit of extra phosphate, is their phosphate control much better? Are they coming off their binders? If we're improving inflammation and uremia, are they less anemic now? Are we using EPO? Are they less inflamed? Are their CRPs lower? Are they eating better? None of that has actually sort of borne out in observational trials. We have not studied it well enough to actually look at direct clinical benefits to the patient. And of course, no one's actually ever done a trial to look at symptomatology. So aside from sort of biochemistry, how patients, it's touchy-feely, but really how patients feel, what is their dialysis-related burden, whether you're using standardized ESAS criteria or other ways to assess dialysis-related quality of life, no one has actually looked at this prospectively or retrospectively. And then the big one, mortality. So I can split this up into what we thought back then and what we think now. And back then, a lot of our data was based on observational data. The four major databases or studies that were looked at was the DOPS data, which of course included a number of European countries. We've got the Risk-Avid data from Italy, the Euclid data, which looked largely at patients from the Czech Republic, Hungary, Italy, and the UK, and then the big UK study. The initial observational data from all of these trials was extremely favorable and gave a very, very good signal that patients might actually have decreased mortality. This got everyone excited, and people started to do randomized controlled trials, as we should. The three major RCTs that have been performed in this area are out of the Netherlands, with about, I think, less than 100 patients from Montreal. From Turkey, known as the Turkish HDF study, and from Spain, known as the EASE-HOLE study. I have to be careful how I say that. So the data from these three randomized trials, unfortunately, hasn't been as strong and as promising as we would like it to be. But let's go through that and why that might be. So here's a summary of the four major observational trials. You've got the DOPS, which had just over 2,000, Euclid 2,500, Risk-Avid in UK less than 1,000 patients. All of them, of course, were largely retrospective, except for the Risk-Avid data. All of them used HDF in some form or another. At that point, people really didn't know much about dosing and volumes, and so they should have pulled things randomly out of the air. They had groups that they came up with. A high volume group was considered anywhere above 15 liters. Anything less than that was less than 15 liters. The Euclid study, I could not for the life of me figure out how much they actually gave to patients. It just said HDF. Risk-Avid, which looked at using bags of substitution fluid, so of course they are using less fluid versus online HDF, which is what's done nowadays. And then the UK study, which gave about 15 liters of fluid. All of them were followed up for about 3 years, except for the UK study, which had a very long a very long observational period of about 18 years. In red, you can see that there was a high signal and high index of suspicion here that people lived longer and did better when they received HDF. Now, what to do with this? People did the right thing. They questioned this and they said, why is that? And can we actually show that it was the HDF that did it and not every other thing that came along with the HDF that patients got? So RCTs came out. Here are the major RCTs, and we'll spend a little bit of time looking at these. So the first study was the contrast study, which enrolled 700 people and followed them for 3 years. They targeted 20 liters of replacement fluid in post-dilution mode and compared it to ongoing hemodialysis. So which either they took patients who were on hemodialysis and they were randomized to either stay on their usual hemodialysis or switch to HDF. The problem is only 1/3 of their patients actually reached the goal of 20 liters. Most of them were somewhere in the 13 to 23 liters range. That was the median, but really only 1/3 of them reached that target 20 liters. And we'll talk about why that might be. Not surprisingly, they found no difference in mortality, but when they went back and did, what some people consider data fudging, it's not data fudging, it's relooking at data with a different eye. When they look at post-hoc data and post-hoc data analysis, they found that the people who actually managed to get high volumes of replacement fluid, so anyone sort of in that 22, 23 liter range, did seem to have a mortality benefit. So that's what they published. Along the same time, a very similar study was going on in Turkey, the Turkish HDF study. Also around 700 people. Follow-up was 2 years. They looked at target volumes of 15 liters, but they actually were able to achieve higher volumes for most of their patients. Nonetheless, even though they reached higher volumes than they wanted to, there was still no difference in mortality and no difference in hospitalization rates. Although, again, when they looked back, because the people from Netherlands reported their post-hoc analysis, the Turkish guys went back and said, well, what happened to our patients who got high volumes? And they also found a signal. They said the ones that got higher volumes, there is a signal for decreased mortality for these patients. And then the Spanish came along and did their study. So they enrolled about 900 people, followed them for 2 years, went or targeted volumes of 18 liters, but they were actually able to get much higher rates than that. They were, on average, achieving about 24 liters of replacement fluid. And boom, there was a signal for mortality reduction that bore out to be somewhere in the 30% range. And when they did their post-hoc analysis, more was more. The signal was stronger the more replacement fluid they got. Now, there is a couple of caveats. Ignore the first box there, but the second box pertains to the EASE-HOLE study. The way that they achieved high replacement fluid rates is by having really good vascular access, because it all goes back to making sure that you're not removing more than a quarter than your incoming blood flow rate, that filtration fraction. So it's the people that had really good blood flow rates and the people who generally ran a bit longer, because that's what allows you to get higher volumes, who were able to get here. And certainly in clinical practice, we have observed the same thing. Who can we get to get those high replacement fluid volumes? It's the people with good vascular access and good blood flow rates, or the people that we can run a little bit longer to achieve those rates. But I think it's worthwhile. I don't want us all to hang our hat on, okay, well, we've got one RCT, it proves the point, let's just move on. It is worth to examine some of the small details in the EASE-HOLE study that may have confounded or at least obscured the data slightly. And that does show up okay. So this is the primary outcome data for the EASE-HOLE study looking at mortality. So you can see the red boxes sort of point out the ones that were actually found to be statistically significantly different between the dialysis and the HDF group. So death from any cause, you had 122 dialysis patients die versus 85 HDF patients. This was clinically, statistically significant with a p-value of 0.1. So we all accept, okay, well, more people died in the dialysis group. But let's look at why that was. Most of that difference came from higher number of strokes in the hemodialysis population and higher number of infections and infection-related mortality in the hemodialysis population. So that's a little bit interesting. Let's look at hospitalization and morbidity and intradialytic symptoms. So what were their hospitalizations due to? So you can see that more people had hospitalizations in the dialysis group versus the HDF group. But why? Why were the hemodialysis patients primarily hospitalized? The red box tells you where the major difference was. It was to do with vascular access issues. On the flip side, if you looked at what could potentially go better and you looked at symptomatic hypotensive events, there is a clear signal here that the people in the HDF group had less intradialytic symptoms and less intradialytic hemodynamic instability. So what can we learn from this? People died in the HDF or in the dialysis group because of infection and stroke. People were hospitalized in the dialysis group because of vascular access related issues. But still, we're seeing a signal here that on average, the HDF patients seem to be more stable during their runs. Now, who were the patients who actually were randomized? We always try to think that RCTs are perfect and the randomization is perfect and the two groups are going to be exactly the same. But look at the hemodialysis group versus the online HDF group. The hemodialysis group was about 2 years older, and in the life of the dialysis patient, that is significant. There were more diabetics in the hemodialysis group. They had a higher comorbidity index, so they were sicker. And strikingly, they were disadvantaged from the get-go. More patients in the dialysis group had catheters. Now, does it make sense that more patients with catheters would have vascular access-related hospitalizations and infections and die less from their endocarditis? Absolutely. So, am I completely discounting the trial? No. But I don't think we should say ESOL proved it and we're going to stick with that and we don't need to do more RCTs. There was a lot of reasons why the HDF group was advantaged right from the get-go, and we do need to keep that in mind. So this is the current state of affair after looking at the data. There is a very strong belief in our hearts that HDF should be better for our patients. There is no question about it. What we are trying to do is to try to prove this, really. And I think that most of the upcoming studies and trials are going to be exploring the role of how much HDF do you really need? What dose of HDF is really good? And the expert opinion that's come out of this is that in post-dilution mode, you want to get at least 20 to 24 liters of replacement fluid going, or else don't even do it. It's a waste of effort, time, money, and everything else involved. So if you're not getting that replacement fluid rate, I question the validity and the efficiency of that. Unfortunately, we don't actually know, based on the trials that have been done so far, who we should put on HDF. So who's going to actually benefit from this? We don't know if starting HDF right from the get-go, in other words, a new patient starting dialysis, why do they have to start dialysis and switch to HDF later? Why can't they just start on HDF? We don't know because it's never been studied. And although we want to really believe it, no one has actually ever shown that if you switch people to HDF or put them on HDF, they're going to feel better, their quality of life improves, their symptoms go down. In our hands, have we seen some of these uremic symptoms improve? Absolutely. We do see, sounds again touchy-feely, but we do see improvements in fatigue, energy level, restless legs, cramps, as well as pruritus, but not in all patients. So it's when it works, but when it doesn't, it doesn't. So if we're going to do this, we have to figure out how. And if we're going to do it, we should only do it if we do it right. So one of the major things we try to do, or have to do really, is we have to get high replacement fluid volumes. We got to go to at least 20 liters, more being more. So if we're targeting 20 liters, keeping in mind that our filtration fraction has to be less than 25% of the incoming blood flow, this chart shows you how important the vascular access and the blood flow rate is in order for us to attain this. In the light gray group there, you've got patients with blood flow rates of 200 mils per minute, running either 3.5, 4, 4.5, or 5 hours. It does not matter what you do. They are not ever going to get to that 20 liters that you need. If you crank that blood flow rate up to about 300, by about 4.5 hours, you might break that target of 20 liters, but you really need a 5-hour run to really get them to that target. Now, if you're lucky enough to get anywhere close to 400 mils per minute, you can definitely get away with a 4-hour run, and if you extend it anywhere beyond that, more is more. So there's really only 2 ways to get that replacement fluid. Either you create and make and maintain the best vascular access and try to get the maximum blood flow rate that you can, or you stretch out the time so that you can get to the replacement fluid. So really, it's a matter of blood flow and duration in order to attain this. And that's definitely something that needs to be considered when we're looking at who we're going to put on HDF and when. And how is that going to fit into how we organize our unit, really? The second caveat to all this is the recognition that although we want to get high replacement fluid rates, in other words, we're trying to get, let's say, for this patient who has an amazing vascular access of 400 mils per minute, we're trying to get 24 liters of replacement fluid. And let's say we try to do this for all of these 3 patients. So the ultrafiltration per minute that we would need just to get the replacement fluid into them is 100 mils per minute. That's already 25% of their incoming blood flow rate, right? But what if that patient actually has fluid to lose, right? We want 2 to 3 liters of ultrafiltration just to get them to euvolemia. You're now adding in 8 to 16 to 25 mils per minute of ultrafiltration to get that 2 liters of volume off, that 4 liters of volume off, or that 6 liters of volume off. That, together with the replacement fluid, will increase the total amount of ultrafiltration, and it's going to exceed that 25% that you are going for. So what do you have to do? You have to dial back on your replacement fluid. And that's okay if the total amount of ultrafiltrate is still somewhere around 20 to 24 liters. But it's something that technically at the bedside we have to keep in mind, that if we're dialing in, if the nurse that day says, well, okay, so you come in at 58, you got to get you down to 55, but the doctor also wants 20 liters of replacement fluid off, that's not going to jive, right? We got to dial back, and we have to decide what the best order set would be to try to make sure that what we're ordering is total ultrafiltrate off for these patients. Does that make sense? Yeah, good. And really, the other big thing that we have to consider is something that we can't really ignore until we're very comfortable with it. And that has to do with how are we going to make our substitution fluid and feel comfortable infusing it into our patients. So this is the diagram that shows how normal dialysate is obtained. You've got municipal water that goes through pretreatment and becomes product water, that goes through a purification process as well as reverse osmosis in order to make dialysate fluid, which is mixed with the acid and base concentrate and then becomes standard dialysate, which we test at regular intervals if we're hopefully following standards that have been put out for us in order to make sure that the bacterial count is less than 100 colony forming units per mil and that the endotoxin count is less than 0.5 endotoxin units per mil. Now, if you have an HDF-ready machine and you have filters that are well within their capacity, half-life, and upkeep, if you run that standard dialysate through filter number 1, you are meant to get ultra-pure dialysate that should meet criteria for ultra-pure dialysate. Those are much more stringent. You're looking at colony forming units of less than 0.1 and endotoxin counts less than 0.03. If you take this ultra-pure dialysate and run it through a second filter, you are meant to attain substitution fluid. And this substitution fluid still has the same endotoxin count as ultra-pure dialysate, but it's that bacterial count that actually uses different units. It's the SAL, and it took me a long time to figure out what this was. But the SAL is basically a sterility assurance level of 6. What that means is that there is a 1 in 10 to the, so 1 in 1 million chance that the sample that you would draw would have a chance of bacterial contamination. And lucky for us, there is no test this sensitive to show you that it's less than 1 in 1 million chance. So even if I wanted to test that fluid, we don't have the test to do it. We don't have a test that's this sensitive. Therefore, testing the substitution fluid is futile because we don't have the means to do it. Testing for the ultra-pure dialysate, different story. You can do this. We have laboratories and abilities to test the fluid that comes out of filter 1 and say, yep, it meets ultra-pure dialysate criteria. The question is, do you have to do this? And that's a question that's heavily debated in Canada and not at all outside of Canada. So if you look at, because we're very careful people, so if you look at the people who have been doing this for a very long time, which is mostly our Japanese colleagues, our European colleagues, not our US colleagues. If you look at the patients who have been on hemodiafiltration and what the major people are doing with how they're running their units, it was very well summarized at a recent talk given at the European Dialysis and Transplantation Association meeting in 2015. Now, the person who gave this talk had some interesting ideas with other things, but nonetheless, I think represented the European voice when it came to what you should do with the water testing. So, how frequently should you test your water? As frequently as you're testing it in hemodialysis. You would follow the same schedule and the same rotation for the machine. Do you need to test the fluid that goes into filter 1 to make sure that it meets standard dialysate criteria? No more than you would just for hemodialysis. So you don't need to make sure that this absolutely is standard dialysate and test it more frequently. As long as you're doing it as part of your hemodialysis upkeep, you're doing okay. Now, do you need ultra-pure dialysis to come out of filter 1? I'm sorry, this should say after filter 1. Do you need to test this? In other words, do you need to prove that after it's gone through filter 1, there's ultra-pure dialysate? No. But why no? Well, let's go on. Do you need to test after filter 2? They're saying no. But the no's are for two different reasons. The test for ultra-pure dialysate is felt to be unnecessary because the manufacturers of these filters and the machines have assured us that if we follow manufacturer recommendations with respect to keeping the filter up to date, changing it when its half-life has expired, and making sure that we're basically using the machine as we should, that we're going to be getting ultra-pure dialysate. Just trust us on that. The no after the test of filter 2 is because we don't have the test that can do it. So the crux of the matter really that comes to, in my mind is really, we know we can't prove we have substitution fluid, but do we at least want to make sure that we have ultra-pure dialysate? Do we need to test this fluid for our purposes before we feel comfortable? And that's something that we have to decide as a province together and hopefully roll out in one center and then share our results provincially and say, you know what, we did it here, not just in one center, but in different centers with different water supplies, different machines, different vintages to their water treatment centers. Some centers are beautifully designed and probably do produce ultra-pure dialysate. Some centers are a little bit older like ours, and we do have biofilm issues. So we do need to take this into consideration and probably have to have a few test sites, do some of these testing, prove that, yep, we're getting what we want, and then at some point just lay it to rest. I think that's probably the smartest way to go about this. So, if we're going to do HDF, what are we looking at on balance? Why should we do it? Why should we not do it? What do we know? What do we not know? So let's look at the potential additional costs that would come into therapy. So one of the potential additional costs is the increased requirement for heparin in order to keep our filters from clotting. Of course, we try to decrease the filtration fraction, but heparin requirements do generally go up. We have seen this. Now, is it a large cost? No, in the realm of things, but it is a cost that we have to factor in. Water testing. If we perform additional water testing, there will be an added cost to that because everything we do costs money, especially when we're testing things. So we have to decide how much are we going to test, how long are we going to test that for, and at some point are we going to stop testing that. That's for us to decide together. And then we have to look at more of the impact on the system and the center. So doing HDF on the machine is, of course, to some point a matter of clicking on the HDF button, make sure our nurses are trained on it, knowing that the tubing is a little bit different and the setup is a little bit different, the alarms have to be managed differently. But one of the major things is actually to use the machine for HDF, it has to go through a complete disinfect cycle. Not the usual 15, 20 minutes that we do between dialysis runs. We're talking the proper thing, which takes about 45 minutes to 1 hour. Now, if you're running a tight unit and you've got the next patient in the bed and you're adding an hour or the next patient sort of knocking at the door, you have to take this into consideration. And it may not be feasible to do HDF in all of your beds. It may be a matter of, again, selecting the right patients and scheduling it properly such that you're filling the gaps and not, really sort of making the maximum use of your time and the maximum use of your patient scheduling system. There will be some additional costs, negligible but there, in terms of disposable and extra tubing that will go along with the HDF filters. What are the potential cost savings? Well, maybe their anemia will get better. Maybe they'll be on less phosphate binders. Maybe their hypertension will improve. Maybe some of these medications may change. We don't know that. Maybe they will have less intradialytic or interdialytic symptoms, less myocardial stunning, less issues with post-dialysis complications. Maybe they'll be in hospital less. Maybe doing HDF 3 times a week would be quite reasonable rather than having these patients run 4 to 5 times a week or very, very long. Maybe it's a reasonable alternative to our patients who are running frequently or longer. And if we're going to use certain machines, we have the option of using online priming and doing away with our normal saline bags in HDF mode, also in other modes. And that would be a potential cost savings. So people who have looked at the cost-utility analysis of this from the major RCTs, I'll summarize the data and say the costs has basically been a wash between the two groups. The only thing we have to figure out is how long we're going to test our water for, because I think the costs comparatively will likely be a wash. The big two unknowns in this is we don't know if the quality of life and their symptomatology will actually improve, and we certainly hope, but we don't know if they're going to live longer. So there's unknowns that we have to factor in here, but it doesn't have to be a bad thing. This is, I think, a time to be excited that maybe this will actually help our patients. So I keep saying more current state of the affair is, I think there is a very good likelihood that doing HDF properly can have short-term and long-term benefits for our patients. I think hoping that they will live longer, by watching them for 2 or 3 years in an RCT may or may not actually be a realistic expectation. And I would argue that we should not do something because we haven't been able that it makes people live longer. And I would argue that few things we do in the world of dialysis we have really good evidence for. On most days, I ask myself, why am I doing this? So I think if we're going to look at anything to do with HDF, the data is not as dismal as we think. It's not as precise and definitive as we would hope, but it's really, I think there's good stuff there that we can definitely employ. So I think if we're going to look at HDF implementation, it can be a very exciting time for us as a province, but we should learn how to do it properly, and we should really learn how to make this informative, educational for us and for our patients. So we need to establish, I think the wrong thing to do would be for all of us to do what we think is the right thing and not collaborate on this together. I think what we need to do is really figure out who are the patients that are going to potentially benefit from this. That's, I think, in my mind, the crux of the matter. Are we going to put the 90-year-old on this? Are we going to put the 20-year-old on this? Are we going to put our obese patients on this? Are we going to put transplant candidates, non-transplant candidates, patients with pruritus? These are all things that we have to really take into account. We have to make sure that we actually deliver the right amount of HDF. In other words, that's where my first slide sort of came. Just prescribing HDF will do nothing. It's the deliverance of the HDF. How much HDF are we actually giving to our patients, and is it the right and the at least minimum amount? We have to figure out the logistics of our water testing, and I propose that we do this together, involving, a few centers that could participate in this before rolling it out sort of provincially. The right thing to do is for all of us to collect our data prospectively. It's the one thing that we can, contribute to the data collection and the observation of things. This has not been done. We need to establish how we're going to look at, are our patients getting better? And it's not useful for me to stand here and say, anecdotally, so-and-so was less itchy. That's great, but we need to actually show that this does make a difference. And we have to maybe look at a few standardized criteria that we're going to look at. Many of our units use ESAS scores. Perhaps this would be a good way to track this, and certainly that's something that we wanted to do when we first started this. And then I think at a center level, we have to look at the center-specific logistics. So you at your center need to know how many patients you have, what machines you have, how tight your schedule is, and how you're going to make this work in the overall realm of things. And with that, I'll end and open up for discussion or questions. Hi. No. No, we have not. We have ourselves not used it in calciphylaxis, in established cases of calciphylaxis. I would be wary to do so because I think that based on our experience, it's the long dialysis and the really intense dialysis that makes a difference for those patients. I don't think the added convective clearance of this would be enough. I would not feel comfortable to do that in my hands. No. Yeah. Yeah, no, we haven't. Yeah.
And then how close are we to having provincial discussions about this and the criteria that it gets started?
Close, I think. Yeah, very close. Yes.
The water testing stuff has already started in centers to establish a network on criteria to our patients.
Yep. Yes.
So for those patients that you have initiated on HDF, what's sort of the duration, those sort of softer markers that you talked about, the quality of life indicators or pruritus, and what kind of time frame have they improved?
I would say within the first 3 to 4 runs, we're seeing changes. Yeah. And it's funny, some of our patients are really become married to the idea that HDF is better for them. And we try to tilt the machine and sometimes not show them that it's an HD run versus an HDF run. And some of them really know. And I still believe that there's a potential placebo effect there, but some of them really know, and there's a definite difference, especially with that post-dialysis washed-out feeling that some of our patients have, that fatigue, energy level. We do see some of them are very, very much affected by it. Yeah, but it's quite quick when it works. Same with the hemodynamic stability issue. Absolutely. Okay. Yeah, please, go ahead.
Are you guys using this in ICU as well? What you guys are looking for CRT or not?
Yeah, in the ICU, we have the option of CRT, and we are using intermittent hemodialysis only. The HDF has been really confined to our in-center unit. I think one of the new exciting things, not new, but exciting things to look for in the future is to do nocturnal HDF. So to have the increased time plus the convective clearance, because we're going to get good replacement volumes in that. And I think that's something we should look at, really.
Sorry, I have another question.
Please.
You talked about having an amazing vascular access, but then also the duration. So how do you sell patients on being there 4.5 or 5 hours? Because I know that can be quite a barrier even for some to stick around for longer than 3 hours.
Absolutely, yeah. I think thankfully the patients that we have approached about doing HDF have been the patients who have had uremic burden and symptoms. And so it's this idea of this might actually make you feel better, but you have to put in a little bit more time. And we certainly aren't, I think that if the patient's not on board, it's not going to work. Right? So we have tended to select patients who are really gung-ho and want to give this a try because they're more likely to be adherent with therapy. Nobody wants to put in the time and the effort to have our patient cut their runs short at 3.5 hours and say, I'm out of here. So it's really been the patients, I think with our selection criteria, we've really selected people who do have those crashes on dialysis, who do report refractory pruritus or uremic symptoms, and it hasn't been a difficult sell for them. It's actually harder to get them off HDF. Yeah. Yes. Hey.
So, as you mentioned earlier, pretty much nothing we've done at dialysis up to this point, changing the dialysis prescription machines, et cetera, has made any real difference in the measured hard outcomes that we can try to look at. And even with extended dialysis, conventional extended or nocturnal or whatever, haven't really shown mortality data yet. And some of the reasons for that are that while dialysis removes, we can remove more during a longer dialysis or et cetera, we actually might be removing more of some other things that might be potentially of benefit. So other than the practical issues of cost and getting something done and getting 24 liters into a patient, do you actually foresee any medical side effects of this therapy?
Mm-hmm. It's an excellent question, and it has not been studied, of course, and you're absolutely right. We think that the protein-bound solutes that we're removing are all really bad and contributing to cardiovascular burden and killing our patients, but you're absolutely right. We are potentially and likely also removing very beneficial molecules. And we've seen this when we were doing high cutoff dialysis and, removing larger molecules and all of a sudden, removing albumin and lipids and other sort of proteins that we think are quite good for our patients. So absolutely. Could there be detrimental effects? Yes. Have we seen those yet? No. Yes.
So I think you mentioned this at the beginning about the fact that we're providing multi-year dialysates as well as the hemodiafiltration. Has there been study on trying to separate those two benefits of ultra-pure dialysate?
Absolutely. There's no question that ultra-pure dialysate is better for our patients. There's been studies to compare ultra-pure dialysate to standard dialysate in the conventional hemodialysis group, and the signal is definitely there that ultra-pure dialysate is good for patients, and that's why it's a big confounder. We don't know if it's the convective clearance or just ultra-pure dialysate that's making the difference here. Excellent questions. Yes?
Has there been a comparison study between a 5-hour HDF and a 5-hour HD and any improvement in symptoms between the two groups at all?
So your question is, I have a patient who's on 4 hours of dialysis, and I'm going to either give them an extra hour of hemodialysis, or I'm going to switch them to an extra hour plus HDF. Yeah. The other way to think of that is, what if I took my 4-hour hemodialysis patient and just switched them to 4 hours of HDF or added on an hour of normal dialysis? And I remember about 4 to 5 years ago, we wanted to push this study through. It hasn't been done. We don't know if more time with diffusion is comparable to added convective clearance on HDF. There's been no head-to-head trials with this.
Probably now, eventually it might be potential.
Absolutely. I mean, now that there's interest in this, we can all work together on making this happen, and looking at our patients and looking at how we're going to implement this and learn from that. Yes?
It's interesting because we're using the Gamma machine for our HDF. We have not increased our heparin on any of our patients. So we haven't had that increase in cost. We haven't extended the length of time at all. We're still getting our BRAPs in, some of them as high as 30. And the patients that really are benefiting from it are
How are you getting 30 liters? Teach me.
I would have to have Gary teach
Because that would mean extremely high blood flow rates in a 4-hour run. So are you getting blood flows of 500 to 600 mils per minute?
350 more volts per line. I think it's the way the machine is delivering the fluid.
Okay. I have something to learn then. Yes?
And any of those patients you were looking at, I'm going back to that study where they were at an advantage because there was more with vascular access as opposed to catheter.
Yes.
Do our catheter patients still benefit?
If the catheter is able to get you the blood flow rate that you need, remember, we think fistulas are better. Largely, I guess that's a topic of debate, but if we take what we believe about fistulas, if we just look at blood flow rates, we all think and hope that blood flow rates through the fistula are better. But there are problematic fistulas out there that you can get that 17-gauge needle or that 16-gauge needle and you're running them at 300, whereas you've got a catheter sitting in the right atrium that's giving you blood flows of 380. So if you've got the blood flow rate, doesn't matter where it comes from, although in that study it was, obviously people with the fistulas did better. Yes. We could overcome that? No. Remember, like anything in dialysis, adding a little bit of this and a little bit of that is not going to make the big picture much different. If they're going to get endocarditis from their catheter, they're still going to die. Whether I remove P-cresol is not going to change that. Yeah. Good? Okay, well, thank you very much.
Thank you very much, Dr. Farah. That was excellent. There is another little half-hour break now, and please, I recommend that you go down and take a look at the posters that are on display downstairs. There should be some more refreshments downstairs, and also please visit the booths of our sponsors. Thanks very much.